working with the inguinal ligamentous tissue, we want to be very gentle with the inguinal tissue because it can be really, really hypersensitive on a majority of people. What I want you to do is I want you to come off of the iliac crest onto the ASIS, and I want you to feel for that ropey tissue that runs from the ASIS all the way over to the pubic tubercle. Now, a lot of people think that there is a direct straight line from the ASIS over to the pubic tubercle, but in reality, this inguinal ligament actually has a curve to it. It actually has a bow to it. There's a saying that there's no straight lines in nature, and the human body is no exception. There is no straight connection from ASIS to pubis in a perfect straight line. It's typically, in 90% or more of the population, it is a bit of a curve. Now, what I also want you to do is, once you've found ASIS and you've found the pubic tubercle, I want you to feel for the femoral vein, artery, and nerve. You're going to feel for that pulse, because we don't want to treat those tissues. We want to primarily be focused on treating the inguinal ligamentous tissue and then the ligamental periosteal junction. So once you've found where that vein, artery, and nerve is, you're going to redirect your focus right to the inferior aspect of that ASIS where the ligamentous tissue is. You're going to come just lateral to it so that you're right sort of at the lateral anterior aspect of it. With your thumbs together, you can slowly engage that tissue down towards the table and a little bit medially. Be careful that you're not working too fast, because if you do, you'll cause an excessive amount of engagement into that tissue, and you'll cause a protective mechanism by where the patient will protect and guard sort of in a way of apprehension, and you'll sort of twang across that ligament like a guitar string. It actually really irritates the patient and hypersensitizes them. So really go nice and slow. Make sure that you've got full contact, very gentle full contact with the lateral aspect, with the anterior aspect of that inguinal ligament. Load down towards the table and a little bit of a scoop medially in order to engage that ligamental periosteal junction, which again is where the highest concentration of mechanoreceptors are for that tissue. Again, we also recognize that we're in contact with the skin, superficial fascial tissue, and any of the musculature that is in this area that this ligament works in series with. So we're going to respect the reciprocal tension of the tissue, respect that protective mechanism. We're trying to change the input into the nervous system so that there is less protective mechanism and more kinesthetic proprioceptive messages being sent from this tissue to the central nervous system. So working with the reciprocal tension, we're looking for an increase in elasticity, a decrease in densification or tone of this tissue. Once it feels like there's a nice amount of balance or elasticity in this area, you can slowly take your thumbs off of that tissue. Don't come out really quickly. Again, you'll just re-engage that protective mechanism for the tissue. With some people, you can actually work right on to the pubic tubercle attachment of the tissue. It's the exact same technique. We're just engaging a little bit slower, a little bit more gentler with this tissue, because closer to the pubic tubercles, it can become actually really, really hypersensitized. Again, when you have completed feeling for a decrease in densification and increase in elasticity, you're going to slowly take your thumbs out, and the treatment technique is done for that patient. But always be aware that you have to check for the pulse, the femoral vein, artery, and nerve in through that femoral triangle. So once you've located where those vessels are, you know where you're not going to be focusing your treatment, and you want to find the ligamental periosteal junction right at that inferior aspect of the ASIS. So let's see what that looks like with our patient on the table. So for this technique, this is the inguinal ligament technique. If you remember, the inguinal ligament runs from the ASIS all the way over to the pubic tubercle. But what we have to be concerned with when treating this tissue is the pulse. Now, there is a femoral vein, artery, and nerve that run through the femoral triangle in through this area. So it's very important that before you treat this structure, that you find the femoral vein, artery, and nerve, and that you feel the pulse, because we don't want to treat those tissues. So once we find where her pulse is, now we know where to stay away from, where our safe zone is above and the safe zone is below into the pubic tubercle. So what I want you to do is, after you've found the femoral vein, artery, and nerve, I want you to come down, find the ASIS, and come down right to the inferior aspect, right where that ligamental periosteal junction is. Right there, usually a little bit sensitive. Remember that the ligamental periosteal junction is where we have the highest concentration of the mechanoreceptors that can provide kinesthetic awareness, balance, coordination, proprioception, and that in instances where there's a protective mechanism, that these mechanoreceptors turn into nociceptors and they send danger messages and threat messages. So in this area, it can be quite sensitive on a number of your patients. So you have to go in with a nice broad hand. If you've noticed, I've kept my hand, I found the pulse, I've slid it up a little bit superiorly to where that ligamental periosteal junction is at the ASIS. And what we're going to do is we're just going to engage the tissue a little bit right at that ligamental periosteal junction, directly from an anterior to a posterior direction. Now remember that we talked earlier about the skin fascia frictionless interface system, which says that we can't hook underneath a transverse process in order to engage the tissue. But with this inguinal ligament, because it's so superficial and it's right at the area where we have the most amount of influence to it, we can actually load it anteriorly, posteriorly, or we can come to the side and we can load from lateral to medial this direction. So we can actually utilize both of these techniques. So for now, we're just going to engage gently into this tissue. We are matching the reciprocal tension of the tissue so that we're not causing a protective mechanism of the neurophysiology in her body. And we're just going to engage it and wait for a softening to occur. I'm still monitoring her pulse at the same time. It's nice to monitor pulses because if you find yourself losing focus, you're working too deep for what the patient's nervous system can handle, typically you'll tend to feel an increase in the pulse, and we don't want that. We want to have the pulse maintained or a slight lowering. So I'm just maintaining right now. How are we doing? Okay. Any of that ache?
No, not in that.
Not in.
Not really, no.
Okay.
It's more local where you are.
More local to where I am. So we're just waiting for a softening to occur in this inguinal ligament at the ASIS ligamental periosteal junction. If I want, I can change my position where I can come just laterally to it, and really it's small movements. We've moved from here to here. It's a couple of millimeters, and then load from lateral to medial and see if that makes a change. Any difference? One way preferred more than the other?
This one sort of causes, yeah, a bit in the back a little more.
This one you feel in the back. Okay.
So, yeah.
So let's stay with this and see if it changes the sensation you've got through the back. Okay, so relax the back, relax the glutes, slow deep breaths. Remember that with any of your patients complaining of biomechanical or neurological discomforts, aches, pains, that it is a biopsychosocial event. So biologically, we're changing the input into the tissue. Psychologically, we need to get them to relax. So informing your patient that and making them aware of what they're holding tension in and getting them to release that tension is a key component to any manual therapy practice. Now it's eased. Okay. So going from the lateral to medial direction, it's eased the pain or the discomfort in the low back. How about going anterior posterior? Did okay?
Yes.
Okay, so there's a softening, there's a more elasticity that's occurred into this inguinal ligament. We've had a decrease in comments for the posterior aspect of the lower back. We can still feel a pulse. If you have someone who complains of pubis or pubic symphysis discomfort, then you can work the inguinal ligament closer to that pubic tubercle. Again, find the pulse. We know where we don't want to be, and then we're going to, this tends to be a little bit more tender right at the pubic tubercle. I'm just going to cross my hands over, find that pubic tubercle, stay away from the pulse, and then load directly anterior to posterior. Now with your thumbs tend to be the strongest areas of your hands, so be very slow and very aware that you're going in nice and slow into this tissue. How are we doing? Doing okay?
Sorry.
Any tenderness, soreness?
No.
Doing okay?
More hand pressure.
More hand pressure. Okay, so there's no comments, there's no issues there. Then slowly come back off. Feel for that pulse again. Go back to that ligamental periosteal junction. Load into the tissue a little bit more, back to where your hand placement and depth was. Anterior posterior. Load medial lateral. The elasticity is still there. And now there's an ache. Okay, so I've engaged a little bit deeper into this area. So I think I want to hold on to this for a second. So right now, for pounds of compression, I'm probably using a good 5-10 pounds. IR. Changing? Staying the same? Slow deep breaths.
Decreased quite a lot.
Okay.
Put it on the left now. So weird.
It's on the left now.
Yeah.
So for those of you that are interested to know why there possibly might be a peripheral pattern on the opposite side or at a distal area to the area that you're working on, then I would refer you guys to go back to the introduction section where there is an in-depth video on the neurophysiological model for referred pain, and that is a great description and knowledge and information about how that occurs. So go back to your introduction section, neurophysiological model for referred pain video, watch that, and that will explain the symptoms that she's having right now while we're treating this area. Okay, I'm going to slowly come back out. And that concludes treatment technique for the inguinal ligament.